perception that patient care is suffering as a result of the patient's prestige. As I mentioned at the start, however, the fellow physician or healthcare colleague's family member or loved one is an extra special subtype of the VIP patient. Not only is there extra pressure exerted on staff and treating physicians by virtue of the patient's status, but there is additional pressure, or perhaps I can even conjecture additional accountability that arises as a result of the patient's medical background and knowledge. At first glance, we might predict that this would bring about an improvement in overall care. Here we are not talking about a famous celebrity or politician making unreasonable, inappropriate demands. We are talking about a fellow physician who understands the medicine and the medical system, adding an informed patient's voice to the conversation. And yet, we have all heard the sayings, doctors make terrible patients, or from William Osler himself, the doctor who treats himself has a fool for a patient. These statements all stem from the recognition that when dealing with one's own health, doctors generally have decreased objectivity. It has been asserted that the doctor who cannot assess a patient objectively is impaired and might as well be intoxicated. Certainly, physicians can and oftentimes do contribute meaningful input into the care provided by other physicians. But the point I've raised just now has contributed to the overall staunch stance by the medical profession of discouraging self-doctoring. We learn from the earliest days of medical school that it is a bad idea. We've all heard of examples from the past of physicians running into trouble with their local professional bodies for self-prescribing. Translated into the situation of the physician as patient, treated by someone else, the takeaway message is that the input from that well-informed patient may lack the degree of objectivity which that patient usually brings to the assessment of his or her own patients. Furthermore, regardless of the doctor-patient's actual input, the care may be different. A study of GPs and consultants in Hampshire, United Kingdom, found that doctors tended to behave differently when seeing a doctor as a patient. The researchers reported that in an encounter with a fellow physician, 26% of doctors would do more investigations, 22% would be more likely to treat, and 46% would be more likely to refer onwards. The medical literature is again rife with examples of how physicians as patients can be worse off compared to their non-medical counterparts. A particularly touching example comes from Dr. Eric Fromm and Dr. J.A. Billings in the 2003 JAMA article entitled Care of the Dying Doctor. And I discussed this with my geriatric consult team last week at the start of the week. The shortcomings of care for the physician with chronic or terminal illness include such things as, one, the treating physician hesitating or refraining from making important recommendations for fear of offending the doctor-patient. Or secondly, pursuing suboptimal therapeutic choices due to deferring to that patient's authority. And thirdly, there being gaps in communication arising from assuming the doctor-patient already knows more than he or she actually does. In Dr. Fromm's paper's specific subjects, there is even the sense of the dying physician being abandoned by his healthcare providers, partly due to the unintentional assumption that the dying physician is already familiar with death and dying, having seen so much of it. Indeed, it is easy to forget that despite many of us working at the interface between life and death on a daily basis, the majority of us will only ever die once in our own lives. And in case you can't see it there, the title of that illustration is The Poor Doctor and the Rich Patient. You are very ill. So thus far, we've established that being a VIP patient can be detrimental. Further to that, we've explored how being a physician can make you a more difficult patient and possibly result in worse care. But in fact, the most common VIP patient we encounter in geriatric medicine, and I suspect in other disciplines as well, is the family member of another physician or healthcare worker, and perhaps the family member or loved one of a colleague. And it is this situation that I'm hoping we can address a little more today, dig into a little bit more. Compared to VIP patients in general, or doctor patients specifically, the care of the physician's family or loved one.
Patient Gregory Hoover, please return to Providence 7 Alpha. Patient Gregory Hoover, please return to Providence 7 Alpha. Patient Gregory Hoover, please return to Providence 7 Alpha.
So compared to VIP patients in general, or specifically doctor patients, the care of physicians' family or loved ones has received relatively little attention in the medical literature. In fact, a literature review in preparation for this talk, I did not unearth any notable empiric research on the topic. The topic has been explored, however, in many opinion pieces, editorials in both medical journals and news outlets, and in qualitative research, often of an ethnography tradition. In a 2015 Internal Journal of Nursing article entitled Ways of Understanding Being a Healthcare Professional in the Role of Family Member of a Patient Admitted to Hospital, a phenomenographic study, Carlson and his team conducted semi-structured interviews of 18 healthcare professionals in 3 Swedish hospitals. They had to have at least 1 year of professional experience, and they had visited a family member in hospital. And this was excluding maternity and psychiatric care. The authors drew from the content of those interviews to describe 4 dominant ways of understanding a family member's experience. That of 1, the informed bystander, 2, the supervisor, 3, the advocate, or 4, the carer. And the first of those, the informed bystander, being the least involved, and the carer more or less taking over the patient's care because of inappropriate, unsafe, or omitted care that the family member witnessed. Apart from being the informed bystander, in all the other ways of being, there was described a difficult balance that the family member struggled with between their loyalty to their family member and their loyalty towards their colleagues among the staff. So if there's anything to take away from this study, I think it's the recognition that there is a real range in the level of involvement that we can expect healthcare professionals will take in the care of their family members when they're admitted to hospital. Eric Fromm, again, in another article, this time with 4 other physicians in 2008 Annals of Internal Medicine, entitled, What to Do When Your Loved One is Ill? The Line Between Physician and Family Member. This article consisted of a series of case studies drawn from the author's own experiences with accompanying commentary. And 3 of the cases or vignettes are categorized as examples of regretful involvement of the physician family member, and 2 of them are categorized as grateful involvement. So, time permitting, I'd like to read out parts from one of each category. So, vignette 1, regretful involvement. My worst moment came last year when my wife was pregnant. In previous years, we'd suffered through 3 miscarriages. And when she started spotting this time, I remember it as my lowest moment in medicine, because I was ward attending and rounding with my team, which had been up all night with 12 patients. We were on rounds, and I was being yelled at by a patient with chronic pain and a personality disorder when my wife called to tell me of her miscarriage. Perhaps you can relate to this to some extent. I couldn't believe that I had to be there at the hospital, being berated for God knows what by a ridiculous, overgrown adolescent while my poor wife was at home with her grief. That night, my wife complained of pain while I was trying to get to sleep. I half-heartedly examined her abdomen. I told her it was probably just cramping from the miscarriage, but she said the pain was different. I remember feeling overwhelmed and resentful. The next day, my wife made an appointment with an obstetrician she'd never seen before, borrowed a car, and drove herself to the appointment. Her obstetrician made the diagnosis of tubal pregnancy clinically, treated her with methotrexate, and ordered ultrasonography just to make sure. The obstetrician called us at home later that afternoon, chagrined to say that the size of the tubal pregnancy required surgery, and requested that we return that evening. The surgery went fine, thank goodness. To this day, I feel shame whenever I think of how I handled that situation. Any objective health professional would have thought about an ectopic pregnancy, but I wasn't being objective. It's not that I didn't think of it. I didn't think about anything. In my state of mind, I didn't want to think about anything. So again, we see the issue of compromised objectivity, but it highlights another aspect of the physician-family member, which is important in our patient population so often, and that is that very often the physician-family member is less objective not only because of the degree of personal attachment, but because he or she is also in a state of suffering. So, vignette number 2, this is a case of grateful involvement. In this next case, the physician reflects on her involvement in the care of her mother-in-law. I coordinated what became for her an intensely complicated medical evaluation. It took a series of false starts and consultations and testing, but ultimately an MRI of her neck showed critical spinal stenosis that was on the verge of transecting her cord. We also learned from her MRI that M had lung cancer. Both problems were operable, and she wanted to rally for both surgeries. But her course after surgery could not have been more problematic. She had post-operative pneumonia and the acute respiratory distress syndrome. She had chest tubes for ventilation-associated pneumothoraces, prolonged altered mental status in the ICU, and hospital-acquired infections. After 4 months on a ventilator, she saw she was not making gains in recovery and chose to have the ICU withdraw support. I had hundreds of opportunities to help M as she navigated through the medical system. Despite my hesitation, I think I seized on nearly every chance. I allowed physician courtesy to work to her advantage, facilitating appointments outside of the usual wait times and communication with the family. I accepted every invitation to listen in on ICU rounds in case my presence could cause the team to be especially thoughtful and thorough. I was vocal when I noticed omissions in her care or decision-making that seemed risky. Some of my interventions were important, like the time I reminded the anesthesiologist who was about to reintubate her with standard technique that she had an unstable cervical spine, or when I pointed out that her antibiotics were missing gram-negative rod coverage. Despite being vigilant, I took great care to avoid being strident or obtrusive toward her treating doctors, fearful that I might make us into a quote-unquote high-maintenance family. She received flagship medical care. I couldn't keep up with the complexity of her case any better than her physicians, but there was no question that my advocacy added value. One of the most important things I think she gained by having a doctor in the family was that she did not feel so vulnerable. She could trust the care she was getting and trust the details were not overlooked. My role in her care felt pivotal, and it was harrowing to have that responsibility, but it made me feel proud to be a doctor and glad to help. Being so involved with M has made me a better advocate for my own patients. If for the moment we overlook the ethical aspects of jumping waiting list queues and the question of whether or not this physician family member presence had something to do with this frail elderly woman with known malignancy being taken to the OR for 2 consecutive operations back to back, we can appreciate that the physician family member involved can provide advocacy in a healthcare system that is daunting and dizzying. I don't know if this woman had a geriatric consultation before her OR, but I would like to think so. Ultimately, the authors of this article claim that overall having a physician as a family member is a good thing because healthcare systems have become so complicated, medical information so difficult to understand, and medical errors so common. It can be a great relief for families to have someone on the inside who is accessible and trustworthy. The authors of this article are certainly not alone in that stance. In a 2001 article in the New York Times entitled "Doctors with Sick Parents, See a System's Flaws," journalist, author, and former New York Times executive editor Linda Villarosa draws attention to the disillusionment many physicians feel when their own parents become vulnerable patients in a large medical system. Her piece references a 2001 Journal of Family Practice article by Dr. Frederick Chen, in which 8 family physicians, who were all also heads of family practice departments at academic centers, were interviewed regarding their experiences of their father's care during serious illness. And the findings were striking. Some of the quotations were as follows. "I knew I could not view the situation objectively. I really tried to walk that line of being just a concerned family member. But when things are so blatantly obvious, I finally couldn't stay in the bushes anymore. I had to come out. You know, what good is all that training if you can't help your own family?" This one is a little bit more dramatic. And I said, "I saw the EKG. It looks like he's had an MI. He's been here for almost an hour. He's not had aspirin or nitroglycerin yet." And the ER doc said, "Well, that's what I'm here to do." And I said, "Well, then don't spend your time trying to figure out if it's indigestion or chest pain." So I'm sure I got labeled, but I could have been a layperson and known you were supposed to get aspirin and nitroglycerin. I couldn't believe they were taking all that time to do that. And in this next one, this physician was asked about what it was like to have to intervene. He said, "Oh, it was terrible. On the other hand, you know, at the end, I was so pushed that I really felt like if I didn't do something, that he would die of iatrogenesis." You are frustrated by the fact that you know they can do a lot better when they really want to. I have 20 years in this place, and damn it, the least they can do is treat my father well. If this is the best they can do, what does it say about the average treatment that the average patient gets? And lastly, it is very scary to me because 99% of the people accessing the systems don't have anybody advocating for them that way. The author reported that some of the physicians questioned their own involvement in the profession and system that can produce such incongruities. And this effect lasted for years, perhaps even decades after that incident, after their interface with healthcare and their father's illness. At the end of the day, our challenge is to provide the best care for all of our patients, including their families. Many sources of many different varieties suggest that care provided to patients with a physician family member is suboptimal or possibly even unsatisfactory. There may be issues of distorted perception at play. Many physicians will, by their training, focus on the negative. Perhaps there is a struggle with shifts in authority and control. And in all of these things, there are recurring themes of deference and intimidation. But the common line of advice that is so often applied to the management of the VIP patient, treat them just the same as any other patient, doesn't seem very helpful. And I doubt that attempting to do so really achieves the best care. If we can try to distill from all the input from both care providers and physician family members, briefly sampled today, if we can distill some key ideas that may help leave you with a little bit of guidance the next time you find yourself looking after the mother of your chief of staff or some other similar situation. And so I wanted to bring these together in 7 key points, and I've chosen 7 because I was told that psychologically that's the limit of what our brains can hold on to. And if you go to a restaurant, the best menus have 7 items. So hopefully you can hold on to at least some of these. So the first is address the relationship explicitly. You cannot ignore the family physician in the room. It won't go away. So the most effective approaches seem to be those in which we call out the uniqueness of the situation and negotiate what kind of role that family member will have. And this may need to be readdressed as needed iteratively. Basically, I realize you're a doctor, and oftentimes physician family members like to be very involved in their care. How do you want to be involved? Do you want to be updated on a daily basis with the medical details? Do you want to be included in our meetings? Do you not want to? But call out that relationship. Don't try to ignore it and hope that it goes away. The care for complex seniors, the care for seniors is complex, especially with chronic or terminal illness, and that's why we have a care team. So a physician family member may very well just represent another seat at that team table. But we have to address the ambiguities in that relationship and set limits on it, establish boundaries. The second thing is perhaps a point of guidance, or perhaps just an acknowledgement that the desire for the family member, for the physician family member to be involved is actually quite appropriate. Physician family members, they have good reason to insist on being involved to a very high degree because we all know about the frequency of medical errors, and we see many instances where standard of care isn't met. We know that medical care in hospital is dangerous. So an acknowledgement that this family member is going to want to be highly involved. The third thing is that ideally we would solicit the input of this physician family member. It comes up again and again in any person who's had this experience. They will talk about their fear of being labeled, their fear of meddling, their fear of stepping on the treating physician or the treating team's toes. And so if we want to be offering the best care to this patient and this family, we should alleviate that fear and actually solicit their input. Ask them what they think. Ask for their opinion. And you don't necessarily have to go along with it. They aren't really the treating care providers. They're not directing care necessarily. But asking for that input will alleviate a lot of that doubting of whether or not to get involved or how involved they can be. Expect more pressure. This is a reality. In every instance of my own personal experiences, and I imagine you can reflect on your own experiences, there's never been a case where I've been looking after a physician's family member that I haven't felt more stressed about it, that I haven't felt more uptight, more on guard, felt that I needed to make sure that all my ducks were in a row, making sure that I wasn't missing anything to a higher degree than I might feel in any other instant. And it won't just be you, but the entire caring team, the nurses involved, the allied health, all will feel that. And basically, I'm just saying that there's no way around it. I didn't mention this during the talk, but it needs to be stressed, confidentiality. Because oftentimes, this is also someone else's place of work. And so you are looking after a patient. And I think we all do this. We kind of have hallway chats about a patient that we happen to be seeing. Oh, and did you know it's so-and-so's father, it's so-and-so's mother's aunt, so on. And it's one of the cracks in confidentiality that's quite common. So that is just a reminder. The medical community can be quite small. The sixth point is to give physicians permission to be family members. They need to be given permission to be family members rather than only healthcare providers. And it's important to try to identify when one role is interfering with the other. This can be a feature particularly with end-of-life issues, withdrawal of therapy, chronic degenerative conditions, and decisions regarding aggressiveness of intervention. One of the articles that I mentioned earlier from Dr. Frum in Care of the Dying Doctor, one of the things that was gathered from the dying patient's son, who happened to also be a physician, was that towards the end of life, as his father was dying, many of the aspects of care were left to him, and it was felt that he would be able to provide that because he was a healthcare professional. But he later on confided that prevented him from actually being able to be a son while his father was dying, because he was essentially too busy being a care provider. And this last point, you can sort of take it or leave it, but my own sense is that these kinds of instances are actually a very useful trigger for reflection, because as I've mentioned, in the situations that I've had myself, I've always felt more pressure. I've always felt more stressed. And there must be a reason for that. That pressure, that dread, that annoyance or threat or defensiveness or fear or pride or honor that you feel treating this patient is a useful trigger for reflection on your medical practice. As one of the excerpts above highlighted, that the experience of being a physician family member to a seriously ill person can drive someone to become a better patient advocate. Likewise, asking yourself why you feel uncertain or defensive in caring for a patient with a physician family member may help identify areas of your own practice that you want to change, or aspects of our medical system that you simply don't see as being right. We will all be the physician family member eventually, if not several times already. And it is disingenuous to suggest that we treat the patient with a physician family member just like any other patient. So in closing, I would just say again that we understand from the very start of our journey in medicine that caring for a patient is a privilege. And it may be that caring for our own is the highest privilege. I'll leave it there with plenty of time for your questions, your comments, and I'd be keen to hear on some of the experiences, particularly those with much longer careers than mine, of how they've navigated this. Thank you. Are there any questions or any comments or personal anecdotes? Yes, Brian.
Thank you for your talk, Dr. Lowe.
I think there's
Can you hear
is there
it?
a microphone that will allow
it is on.
another site
It
to
is
hear
on.
you?
Thank you for your talk. My question's relating to a topic you mentioned but wanted to set aside, and I wonder if I could bring it forth. And in particular, when I think about the VIP patient, I think, especially in the context of our medical system, I think about this issue of access and about how sometimes the VIP patient, like these people, might get things that the general public wouldn't get, whether that's timing to a procedure or a speed of a referral, or even access. I've seen, just in clinical rotations, someone can walk into a clinic when they don't have an appointment and get things taken care of very quickly. I wonder if you could comment on that and how that plays a role in this story as well.
I don't want to sound too cynical. I remember a number of years ago, it was many years ago, there was something in the paper about Nicole Kidman, and she had had a minor accident or something, and it was a big scare. She had to go to the hospital, and she commended the staff there and praised the hospital and said it was fine. It was a walk-in, walk-out affair. And I suppose part of it is when we talk about people with prestige, it's also people with influence. And when you recognize that a person has a very tall soapbox to stand on or has a speakerphone and is able to reach many, many people, then it becomes more of a priority to make sure that that person is appeased or pacified. If Taylor Swift showed up in the emergency room here, unless we wanted half the population of the United States and maybe Canada to be upset with us, then we would do everything we can to make sure that she's happy and tweets something positive. So long as we as people are still in charge of doling out our services and distributing our services, I believe that those inequalities and injustices will persist as a matter of self-preservation. I guess that is rather cynical, even though I hope not to be, but yeah. Yes?
I have an anecdote to share. When my father was post-op had hip surgery, had an MI, and then got pneumonia, and I remember being in Morning Report and getting a phone call to come back to Toronto, and it was at the Western Hospital where I'd been the chief resident, worked for 3 years, knew everybody there and everything, got there and just couldn't get proper information, like the respect that I thought I deserved as a former physician there, and I was getting kind of frustrated, and the attending physician came and showed me my dad's x-ray. And that ended all my concerns, etc. It explained the case, it explained the management, just looking at the x-ray, and all was good. So I would just support sharing medical information and sharing your thoughts and rationales with people that can understand that on that level. And that's the same thing with patients, right? You just share everything you know about the patient medically that the patient can handle. You do the same thing with family members that are doctors, and I think that works pretty well. So it worked for them sharing that with me, and I had the full understanding immediately after I looked at his x-ray.
Thank you. Thanks for sharing that. Yeah. Yes.
Thanks for your talk. Can you share any strategies on setting boundaries when you feel that the physician family member might be behaving inappropriately? The anecdote I have to share is getting paged in the evening by a physician who I don't have any relationship with. I don't know this person, who was actually advocating for his wife, who was also a physician. And it was a long phone call of me being berated for not coming in to see this patient when there was a clear plan in place and no clinical change. So I found that to be both a stressful and frustrating situation, which obviously eventually self-resolved. But if you have any comments about setting boundaries in that type of scenario.
So at the far end of the spectrum, the final act is to pass on the care of the person to someone else. Because all of us will have a certain style or pattern of practice, and it might be that in that patient or family member's mind, you would be working 24 hours a day and you would be available at any moment to come and assess the patient. But that may not be the system in which you're working, and that may not be the style or the format of your practice. And you can't, obviously we can't be everything to every patient and redesign ourselves each time in order to satisfy all those needs. And so the hard line at the end is that if there's an incongruency in how we see this person's care needing to be met, then I need to refer you to someone else. Short of that, however, there is a lot of negotiation that can go on. And so, I mean, the particular incident you're talking about is a little bit different from what I'm about to say, in that there's a difference of acuity there. But what I have found when it comes to physician family members and their need for attention, it's often that they need to have the information, and they need to have it pretty consistently. They're not necessarily going to wait until the next time the team happens to come around or something, or wait until the next day. So if you establish certain ground rules as to when you will be available and what the course of action is outside of those times when you're not available preemptively, then that can help. So again, that idea of addressing the relationship ideal at the onset. I mean, it's sort of a growing list of things that you kind of have to do when you first meet a patient. You have to establish their code status, and then establish their advanced care directive and all these kinds of things. And you have to establish what your working relationship is going to be. If you do that at the onset before things start to get hairy, then that can help. I mean, I'm certainly no expert, so I don't think I have a better solution than what you probably managed to come up with. But how if I can ask, how did you resolve that?
Well, it was difficult. I wasn't really involved in that patient's care, but I had already heard about this patient from my colleague, partly because the patient was a physician. So because of that, I was armed with at least some information that allowed me to discuss the care in what I thought was a reasonable manner. So it was really a matter of ensuring that, kind of trying to de-escalate the situation, because I think fear was driving the encounter that we had primarily, and trying to provide reassurance and a clear plan as to what the next steps were going to be the following day with the usual treating physician, my colleague, and then making sure that I had written documentation and, again, verbally followed up with my colleague to make sure that nothing would be falling through the cracks. But yeah, it's hard not to kind of react emotionally, right? But it's because the patient family member is reacting to their own emotional state. So it's not about you in a lot of situations, but it's kind of tough to see through that right in the moment. Yeah.
I have a question. It's an anecdotal question, plus maybe just advice, I guess, for all of us in the room. When my dad was dying, he lived in Chilliwack, and the resources for palliative care support were slim to none for him. And I felt often that I was walking the line of being an advocate / physician to access care for him. So I guess my question really is, what advice do you have for healthcare providers when they're in that ethical dilemma of when there is scarce resources and there are no resources, you can't access resources because of system inequalities? I don't know if it's an unanswerable question, but sometimes it's the reality of our healthcare system.
Mm-hmm. I don't have a ready answer for that. It really gets at a very, very big question, because the advocacy for the individual and the advocacy for the group are very different things. And how do we establish that balance? And I think in healthcare, we confront that conflict persistently, repeatedly, because as individuals living in society, we are advocating for our own needs all the time. And yet, oftentimes in healthcare we're making decisions, and a lot of our medical guidelines are developed around the principle of advocating for the group and therefore a distribution of resources. So I make this argument oftentimes, like when in geriatrics, and I'll tell trainees, there's hardly an individual on the planet who wouldn't benefit from physiotherapy and rehab, but we don't send every patient to rehab, and that's a result of resource allocation. But if I'm a family member of a person who's had a stroke and hasn't shown any signs of improvement for 4 weeks, I would still want my family member to get rehab. And I suspect as an individual, I would still push for it. So, you know, it's kind of like whether you would encourage your own children to go to war to fight for your country. You know, there are individual priorities, and there are group priorities, and so it's very personal where you put yourself along that spectrum. And I imagine that it'll shift from circumstance to circumstance. Mm-hmm. Yes.
I was just going to say, in answer to Jane's question, maybe that we've had patients where there have been less palliative care, let's say, available, and if a family member calls, I mean, I guess it's more applicable to a sophisticated patient that would know, but let's say somebody called us and said, look, my family member is in such and such place and there's no palliative care, can you talk to their family doctor? So we've had cases like that where we kind of like the race line, but not specific. And then we just talk to the family doctor, and there's been some conversations. So I've had that with some people that I know, but it would be better in a center like, or in a place like BC where there's more communication lines, because you don't really need to have a full-time, let's say, palliative care physician in a place where there's a small community. You might need, but you may not need. And so a lot of stuff can probably be done over the phone, I think.
I'm sorry, I didn't really look at the screen, so I don't know if there are any questions or comments from the other sites. Doesn't look like it.
So, well, if there's no further questions, I just want to take this opportunity to thank Dr. Lowe for a very thought-provoking talk for a lot of us, I think, in the healthcare profession, in our roles as family members and healthcare providers. So thank you, Lawrence.
Thank you.
Interesting. Really interesting. I was going to say one more thing, but I decided not to.
Oh.
Just how I think physicians are under pressure from their own families, and that can add to the soup a little bit. Like, well, you get in there. Why isn't this happening? Like, you know, I had that for my own grandpa in a nursing home with Parkinson's, and I was falling and having hallucinations. Like, what about a Cinnamon? And what about this and that? And you're like, oh boy, right? Deep breaths. Deep breaths. Yeah, they expect
you have to draw boundaries with your own family, right?
Yeah. It's so hard,
especially when they're at a distance. And it's like, what is the contingency plan?
Well, you've been through that yourself.
What are you going to do?
In a major way.
You call me at 10 p.m. Like, what am I going to say to you except either go to the ER or probably it's okay to wait until the morning, but I can't really tell if it's scary, right?
No, don't. You've been through that yourself.
Yeah, I always end up saying go to the ER.
What's that?
I always end up saying go to the ER because otherwise, like, I don't know.
But I don't know. I think we've gotten to the. It's a continuum, right? Because now sometimes they'll phone and they'll be like, "Oh yeah, we got discharged from the ER yesterday," and I was like, "You what?" You know, because they don't want to bother.
Yeah.
So it's like how you communicate with them can be very delicate in terms of like, yes, you still want to know, But when they're scared, maybe they can't make a rational decision about whether or not to call you or not call you, right? Yeah. Even if you set out all these like supposed framework or a plan.
So people work. Depending on how they feel. How guilty, how stressed, how in control, how unsure. Yeah. That's fine. That's fun. That's good.
Good work. Where are you working? Where are you walking?
Nice talk, Dr. Will. Oh, I'm a total cynic too about that kind of stuff. It's not even necessarily famous people. It's also like people that doctor friends, you know, kind of just like jump at you type thing, you know. Or things I've seen happen. Or even like residents, like a resident, like fractured. I've been myself and changed his cast and took care of him and stuff. Yeah, you know. But actually, when his follicle went, he had to wait like everyone else. So
okay.
I agree with you. It was good.
Oh, thanks.
You know, I find I'm going to add one more comment that I've had before where they don't declare it, but then you find out, not necessarily from them, but that they are VIP, and they don't expect anything extra. And then you say, whoa, like there was a patient who was the sister of a very, very, very famous singer in the United States. And they had different last names, so it didn't occur to me. But I would have treated her the same anyway. But then when you called, I thought, whoa, maybe I should have done something more. But there was nothing more that we could have done more. Yeah. And he was way more demanding than the actual patient. Or he just wanted, he thought that she was ending for better service. But the patient said, oh no, I'm very, very pleased with nothing more to do. But that was an interesting experience. And there have been some famous executives that have been patients and that they don't like anymore.
Yeah.
Sometimes it can go the other way too.
Yeah. Yeah, certainly.
At the end of the day, we're all humans, right?
I mean, when I was doing this talk and I was going through it, it got me thinking. It's odd. It's peculiar how part of our effectiveness as healthcare providers seems to be tied into our ability to devalue a person. Because if, in an idealistic way, you might suppose that every patient that we see is going to be a VIP. And you know, I think every family would want us to think of every patient that way. Like, you know,
that's right.
That this person is the most important. But at the same time, we credit a lot of our effectiveness. Thanks. With being able to be dispassionate, and part of that comes from not actually thinking the person is that valuable. It's kind of like a surgeon who
or you just think of
throws the hunk of meat on the table.
Or you think of everybody as valuable.
Yeah.
And you become passionate about everybody. Which is probably better and more rewarding.
Yeah. So, you know, the idea is then, like, if you look at how it is that we behave, how it is that we respond to these scenarios where we're looking after a VIP or someone who's personally important to us, and why is it that perhaps the effort should be made to elevate our care of everyone else to that standard,
that's it.
rather than...
I think that was the take-home message, that you should treat everybody like it's your
Yeah.
Like, it was just a couple weeks ago, my 5-year-old, he hurt his leg and he didn't want to go to school, so Debbie brought him with him to work. And I went into emergency. I said, Dad, let me just see how busy they are in emergency. There's no use to be sitting here for 5 hours. So I bumped into one of the emergency in the hallway and I said, is it a long wait? I just wanted you to have a quick look at his leg and see if you need to do an x-ray. He actually broke it during floor hockey. And he said, Gil, it's very busy. You'll just have to wait. I was like, okay, that's cool. I didn't. You just have to wait, and he was going to sit with Debbie on the 5th floor. And then about, 5 minutes later, he called me on myself and he said, I'm sorry that I was a little bit fast with you, but obviously you can come down and we'll see you right away. So I was a little bit, because he was stressed, I guess, because he was very busy in emerge, and then he had second thoughts and stuff. But I said, we can wait, like it's not urgent. He said, no, come down now, and it's on very quickly, and it's fine. But I felt that he felt bad that he was, because I didn't necessarily think that we needed to be seen faster. I just wanted to know how long. If you want to sit in emergency, sort of waiting. So yeah, I think it's not, you don't want people to go out of their way, but you just want to, I don't know, it's a weird, I thought that was a weird experience.
Yeah.
Debbie didn't think anything of it. She said, right, of course we should be seen faster. She said, of course he needs to get back to school.
I just wanted to say, I'm Anna Ramani.
Yeah.
Might not
yeah,
before,
kind of.
I just wanted to say it was an excellent talk.
Thank you. Thanks for saying that.
It's kind of interesting because when you look back, you don't get much time to stop for reflect, but once someone talks about it and you have a moment to sit and think about it, you realize that it does happen often enough. I remember when I had just started practice, a VIP got admitted under me, and I was like, "This is probably more stressful than a VIP." Was the other VIPs in the hospital dropping cards to tell me there was a VIP?
I know.
Oh my goodness.
And I think it was throughout the day. I would just run, like people would just come up and then you realize there's a, like, I've been told the first time telling me there's a VIP. And so it was, I remember that was a psychological scar for me that early in my practice, especially when you're so very new and
it's stressful.
And so like you still kind of look at these very more elderly physicians dropping by and constantly checking on you. You kind of feel like you don't trust me, and maybe I should have been like, maybe you should go and hear someone else.
Yeah.
You start to doubt yourself as a doctor. You know, at the end of it, the family was very grateful and nothing happened. But I think there's that aspect of it as well, where even like senior physician versus the best student I could do in your position within the same hospital, and the stress that you experience. From a true VIP, that's what you probably remember. The true VIP comes through.
That's right. Yes. Yeah.
There was somebody last week actually that Jonathan Leipzig, who's a radiologist, called me and he said, "Gil, his family is bugging me like crazy. Can you please? You needed some help to call one of the oncologists that I knew." So I called the oncologist. He called me back right away, and I don't often speak to him. And he said, "Are you calling about so-and-so?" I said, "He said, I already got 3 calls about that person.
Oh, my goodness.
I know we're going to see him today. It's a normal lymphoma. We're going to see him today for sure." And I said to him, he's Diego, and I said, "Diego," because he was just a year ahead of me. I said, "Diego, you may not want to give out your cell phone because this family member is going to call you for sure. They're very nice, but they're going to call you for sure." He said, No. I'm only giving them my first name, no cell phone, no email, nothing." So I think everybody experiences it. Yeah. But it's good to have some guidelines. That's why I think these kind of talks are useful. Behavioral talks. All right, good to
thank
see
you.
And then also, I just want to point out, the patient has a lot of geriatric We'll talk more about those today. I just make sure it's still okay. And then, if it's okay, we're going to talk about what's his name? Yeah. This is all one name? Okay. What would you? Okay. You can do that. Yeah, because the file is going to come later. If you want to outline that, we'll do that. Yeah, okay. Oh, October. Yeah.
Your call will be disconnected.